We want to begin with our first speaker, and we really are honored to have Dr. John Balbus lead us off. He's the interim director at HHS for the Office of Climate Change and Health Equity. He is extremely well known in this field. He's been with NIH, very accomplished, and most of us feel the very best pick for the job he's doing now. And it really is kind of interesting. Alice and I are conducting this session from the American Geophysical Union, and Dr. Balbus is the president-elect of GeoHealth, which is part of that. So with that, Dr. Balbus, thank you so much for joining us, and we'll look forward to what you have to say.
Great. Thank you so much, Dr. James, and thanks, Alice, and the organizers of this conference. So I've been asked to open us up with a report from Glasgow, and all of you are, I'm sure, aware that Glasgow was the site of the most recent meeting called the Conference of Parties, or a COP. And in this case, it was the 26th Conference of Parties of the UN Framework Convention on Climate Change, which is where the nations come together to make agreements on how they're going to combat climate change. If you have been following the news and hearing the discussion of the outcomes, a lot of the discussion is focusing on the main outcome, which was that the nations of the world decided that the commitments that they had made coming into COP26 were insufficient to keep the world anywhere close to a 1.5 degrees centigrade increase over the coming years. And so there was a decision, the Glasgow Agreement was to come back next year when the meeting's in Sharm el-Sheikh in Egypt to have a more ambitious set of climate goals. What was lost in many ways in the coverage, in the coverage of the meeting was what I think is going to turn out to be a watershed moment for the field that I've been involved in for 27 years, and which is the theme of the meeting today, which is climate change and human health. We had a strong presence there. The WHO had a pavilion. They had some 60, I believe, sessions and talks and conferences. But what I'm going to talk about, and what I'd love to be able to show you pictures of at some point, was that this was also the first conference of the parties in which countries of the world came together on health. And some 51 countries decided that they would join a COP26 health program. Thank you. I'm happy to share my screen now. So first of all, this was a picture of again, something that was a first out of the 26 COPs. This was the first COP ever to have a US delegation from the Department of Health and Human Services. So here's a picture of our delegation. Next to me is the Assistant Secretary for Health, Admiral Rachel Levine, and then staff from the Office of Global Affairs who were helping to organize what goes on at these meetings, which is not just the presentations that we made as speakers and representatives of the United States, but a whole lot of bilateral sessions and meetings, which I won't have time to talk about. But here are pictures of what I was describing as a watershed moment. We were able, as the United States, to join this COP26 health program. And here are just images of Dr. Levine making the initial announcement at the Global Conference on Health and Climate Change, and then Admiral Levine, Dr. Levine, with the UN Permanent Representative from Fiji, and Dr. Maria Neira of the World Health Organization at a plenary session of the main meeting, describing the 51 countries that have committed to the COP26 health program. So what is in the COP26 health program? It was organized by the World Health Organization and the United Kingdom presidency of this meeting. And they asked countries to commit in two areas, in resilient health systems and low carbon health systems. And they asked countries to commit to doing a vulnerability and adaptation assessment, which is climate parlance. It's what we do as health impact assessments for climate change. And that the countries use those adaptation assessments, those vulnerability assessments, to help to craft a national adaptation plan for health. Part of the COP is that countries have to produce a national adaptation plan as part of their nationally determined contributions. So these would be health national adaptation plans. And then on the low carbon side, there was a call for countries to institute greenhouse gas accounting, come up with a plan to reduce greenhouse gases from the health sector, because the health sector globally is about 4 to 5% of all greenhouse gases are associated with the health sector. And then and in that plan to account for or to discuss the health benefits that would accrue from the reductions in greenhouse gas emissions, and also to set a net zero target. So for the US, because our health system is enormous, ours is 8.5% of our global emissions are associated with the health sector, so twice that of the global average. And we're 80%, 90% private. Our health system is different from a lot of other countries. We committed to do this vulnerability and adaptation assessment in a national adaptation plan, and also to assist health systems in our country, the private health systems, with doing their own vulnerability assessments and their own adaptation plans for climate change by providing tools and incentives. And then on the low carbon health systems, we committed to as part of the Biden administration's economy-wide commitment to a net zero economy by 2045 and 50 to 52% reduction in greenhouse gases by 2030, that we would be a convening force for the federal health systems, the biggest ones being the VA and the Department of Defense, to help them with, to work with them and harmonize and share best practices in greenhouse gas accounting and greenhouse gas reduction measures for health systems. And also, very importantly, to be partnering with the private health sector. We'll be doing this primarily through an action collaborative of the National Academy of Medicine to help move the private sector along in alignment with these ultimate goals of net zero by 2045 or 2050. So our Office of Climate Change and Health Equity it's a small office. When we are allowed to fully staff ourselves, we'll be up at 8 people. We will have lots of partners, fellows, interns, et cetera, but we want to be the catalyst for this action. And so this is the description of how we hope to accomplish all of these things. We will be, we're already underway with work through our regional offices, and also we'll be rolling out more stakeholder engagement in an iterative fashion to work not just on the vulnerabilities, because we've done this, we've been through several national climate assessments. We've done a good health assessment in 2016. The 5th National Climate Assessment is underway, and we'll update that. But we will be working on understanding adaptation gaps and resilience gaps, and understanding as best we can the lived experience of communities, whether they're in the northwestern coast of Alaska or in low-lying flooded areas of Detroit, or in the Louisiana coastal parishes where there's recurrent hurricanes and devastation, and figuring out how do we protect people better, because people are suffering in these areas. We will be collaborating with other parts of the Department of Health and Human Services on the toolkits. Some of these toolkits are existing. We've helped to create some of these, and we'll be updating them. And ultimately, we will be using the HHS climate adaptation and resilience planning process to iteratively produce a strong national adaptation plan for health, ultimately with other industry agency partners. In the interest of time, I've talked about what we're doing there in many ways on the low carbon health system. So I'm just going to move ahead. And just again, to reiterate, our Office of Climate Change and Health Equity was mandated by Executive Order 14008 in January, tackling the climate crisis. It was one of 3 mandates for the Department of Health and Human Services. The first being to create the office, the second being to stand up a new interagency working group on protecting vulnerable populations from the risks of climate change, and the third to stand up a biennial healthcare system readiness advisory council, the last of which had very little language that described the details of that, and we're working on that. It's certainly something we will be doing in close coordination with the existing MIT flag, with the existing 16th security area, with the existing critical infrastructure program of ASPR and the existing healthcare and public health sector coordinating councils, the private sector council and the governmental coordinating council that ASPR runs. So just to step back for a second, that's the update from Glasgow. I'm very excited to be in a position to help to implement and fulfill these commitments that we've made at COP26. Our focus today is on disasters, but I want to put the disasters and public health in the context of the broader health impacts of climate change. Climate change certainly fuels weather-related disasters, the hurricanes, the extreme flooding events, the severe droughts. But it's been framed more as a slowly unfolding and increasingly and worsening public health emergency. And so it has elements that are acute, severe, noticeable, and cause death and destruction through the fueling of intense precipitation events, the slowing of hurricanes that's been going on that allows them to persist over one place and set record rainfalls as happened in Houston. The unprecedented heat waves such as we had in the Northwest this past June in Seattle that were, nearly 100% attributable by the scientific reckoning to climate change. But then there's more subtle changes. There's changes in vector ecology. There's changes in snowpack and water supplies in arid areas like most of the state of California. And these have more subtle and slowly moving impacts. This is a slide from colleagues at the CDC, just showing at the core the climate-related phenomena of rising temperatures, extreme events, sea level rise, and CO2 levels increasing, and how in this slide they have 8 different exposure pathways through weather, air pollution, vector ecology, increasing allergens, water quality, water and food supply impacts, and some of the more subtle changes in environmental degradation, loss of water supplies, salination of low-lying land, et cetera, that lead to more pervasive societal disruption. So over the day, I won't be speaking to each of these, but I just wanted to emphasize that as we think about the health the resilience of health systems, we need to be thinking simultaneously about resilience to extreme events, to the wildfires that we've seen in the west of this country, in a setting of perhaps pervasive drought and degradation of water supplies and communities that are suffering because they are lacking access to potable water, as other things are going on. And we'll come back to that theme. And we are an Office of Climate Change and Health Equity. This is, I won't have time with my 7 minutes remaining to explain this in full force. I'm going to show some images that start to convey this. But this is a graphic that we created in the Climate and Health Assessment from 2016 that just shows how the social determinants of health interact with the 3 elements of climate change vulnerability as laid out by the Intergovernmental Panel on Climate Change, which are exposure, that people can be placed in the way of harm because of poverty, because of racial discrimination. We'll talk about that in a second. That people can be more sensitive to a heat wave or to wildfire smoke because their conditions have led them to underlying health disparities, whether that's asthma, obesity, diabetes, hypertension, mental stress, chronic psychological stress, and depression, or simply that people lack the capacity to protect themselves, to have air conditioning working, to have air filters in their home, to be able to get themselves out of the path of a hurricane, to be able to get themselves to shelters, et cetera. I'm just going to show some images about how this plays out in American cities and the connection that this administration is making. This administration, as you know, has the four primary priorities of racial justice, economic recovery, addressing the COVID pandemic, and dealing with climate change. And all of these converge when we start thinking about climate change and health. This is a slide from the city of Richmond showing one of the very first maps in which neighborhoods were graded on a color code from green to red based on the perceived financial risk of investing in mortgages or investing in other ways in these neighborhoods. And the fact that the red were the highest risk has given it the name redlining. And overwhelmingly, the communities across the country that were redlined were where the vast majority of people of color, of Black, brown people, and in some cases, Asian and indigenous people would have their homes. And many of you are aware there have been studies just in the last few years linking this history of redlining to present day deprivation of social determinants of health and present day adverse health outcomes, from chronic diseases like asthma to preterm birth, et cetera. So I'm just going to show some slides that show what this looks like for the city of Richmond in a climate change context. So this is a present day map of the tree cover, and you can see that you'll keep your eye to the right side, which is where the non-center city redlined neighborhoods were, compared to the left, which is the west side, where the richer neighborhoods were. The redline areas now, 80 years later, have much less tree cover. They have much more impervious surface and pavement. And if you take those two things together, less trees, more pavement, what you get is a map that looks like this of summer temperatures. So these areas that were designated as being undesirable for financial investment on primarily racial grounds, racial bias, now have disparate exposures to heat, and combined with the poverty that has many people in these areas not able to afford full air conditioning, that puts people at risk from climate change health impacts. Of course, it's not just Richmond. This is a red line map of the city of New Orleans from the 30s, showing again the areas that were of high financial risk in red, the areas of low financial risk, which were primarily white areas, in green. And this is the map that the picture many of you have seen from space of the city of New Orleans a couple of days after Katrina hit and the day after the levees broke in 2005. And you can see there is, off to the right side of the screen, a high correlation of the areas that were low-lying, that never got the investment infrastructure to protect them properly when Katrina hit. And it's not just loss of homes, it's not just loss of life from drowning and flooding. There's a really strong correlation between areas that get flooded and historical environmental justice issues. So on the left is a picture from Hurricane Florence in North Carolina, which was one of the homes of environmental justice, showing the seepage of raw pig sewage out into the water in the areas that had been, complaining about the odors before, and now they had the water on their land from the pig sewage. And on the right is a slide from Edison, New Jersey, just a demonstration that areas that were historical Superfund legacy sites, which are now low-income neighborhoods. This is also true a lot in the Bronx when Superstorm Sandy hit. These legacy Superfund sites were flooded, and people's homes were flooded with toxic chemicals as well as just water. And these, I'm just going to build this out real quick. I'm running out of time, but just to also emphasize that when hurricanes hit and health systems aren't hardened and they're not resilient, people die because they lose access. And the infographic on the right was just the analysis from Hurricane Maria, showing the thousands of estimated excess deaths, not from being drowned or hit by debris, but from the loss of access to care. And lastly, just a reminder that even as we are in the midst of the COVID, and even as today we're dealing with this Omicron variant and the waves of this pandemic, that we can't take our eyes off the fact that climate change is making other kinds of disasters more frequent and we have to be able to walk and chew gum. We have to be able to deal with the current crisis and the long-term crisis as well. So in summary, I just want to emphasize that the people who are in harm's way from natural disasters are not there randomly, that there is a very strong correlation of historical discrimination. You can play this out in virtually every city in the country. And then there's also discrimination in rural areas and discrimination in where, of course, the indigenous people of this country are located. And this plays out into health impacts because of higher exposure, greater sensitivity from deprivation of the social determinants, greater vulnerability. And this is the mission of our office, to try to do something about, to harness the power of the Department of Health and Human Services and all the federal government to do a better job of protecting those populations. So thank you. This is our website. It's pretty simple. We're the OCHI. If you go to our website, you can sign on for our listserv. We are just ramping up. Keep an eye on us, and I look forward to any questions that we may have.
Dr. Balbus, thank you very much. That really paints the landscape, and can't envy you for what your office has to accomplish over the next few years. There was one quick question, if you could just address from one of the audience, and that is the role of urban planners interacting with your office going forward.
We have not formally established that, but it's a great question, and that is where we need to be focusing. It's the planners and it's the emergency managers. A lot of the work, the CDC Climate and Health Program has focused on the local public health departments with the BRACE program, and that's super important, and they've done great work. But where the rubber is going to meet the road in terms of the infrastructure bills, especially as trillions of dollars start flowing into communities around the country, is going to be the planners. We're working, the CEQ is I don't have time to go into all of it, but we're looking at zoning and building codes as well, and planning codes, because that has to be, it's complicated, it's local, but that is the solution space. So yes, thank you, and cognizant of that, and very, very welcoming of any suggestions for partnerships or anybody who wants to talk about that.
Well, again, thank you. And we sincerely look forward to working with your office and supporting your office. And, when there are things we can help with, please let us know.